Good afternoon, everybody. It's a great pleasure to be with you this afternoon, to be chairing this joint session of the Physiological and the Intensive Care Societies. And this next session is on skeletal muscle. And our first speaker is my colleague, Dr. Zudin Puthucheary, who unfortunately can't be with us today, but he has provided us with a recorded offering. Zudin, as many of you will know, is a consultant in intensive care medicine and a senior lecturer at Queen Mary's University of London, working clinically at the Royal London Hospital. And for a long time, he's had an interest in recovery from critical illness and also specifically about skeletal muscle. So he's an ideal person to start us off with this next session. So hopefully his offering will appear very shortly. Thank you.
Hello, everybody. I'm going to talk about COVID-19 and skeletal muscle. And the subtitle I've chosen for this is The Hunt for a Zebra Amongst Horses. So first off, my disclosures. Which I have to do that way. And these are my disclosures. I work with all these companies looking to develop interventions for prevention of acute skeletal muscle wasting in critically ill patients. So COVID-19, for the majority of the population, will manifest itself in the form of a cold, a cough, a fever, in some cases, like myself, pericarditis, but these are self-limiting illnesses. Clearly, there's a spectrum of disease that goes across from long COVID to hospital admissions requiring oxygen, all the way to critical care and multi-organ failure. So we have multiple presentations managed by many different teams, and muscle wasting and fatigue are likely to be related to the severity of disease. And what has been put forward several times and hypothesized that there are unique mechanisms behind muscle wasting in COVID-19, and functional recovery from COVID-19 is going to be different from that of critically ill patients. So I'm going to talk about the critically ill COVID patient, because like in non-COVID patients, these are probably the most polarized examples of muscle wasting and functional disability. Hopefully will give us the greatest chance to look at the signal to noise ratio and understand the mechanisms behind this. I'm going to talk a little bit about the common mechanisms that we know about the COVID patient, not the non-COVID patients, and how these may or may not relate to the COVID patients. And fundamentally, this is about the interaction between physiology and metabolism. Though I appreciate there'll be members of the Physiological Society who believe that metabolism is just physiology. So this is my go-to slide and framework for prevention and treatment of acquired functional disability, looking at the peak of functional disability, which is what our patients see, and diving down into the mechanisms behind each component of it. And you can see on the sides why I look at this fashion, because we need to look at how interventions we need to develop and the outcomes that we need to measure. So starting at the top, functional disability, what is seen by our patients? And we have data from this, from the framework that was put together by the Intensive Care Society with the British Society of Rehabilitation Medicine responding to COVID-19 and beyond. And from this, the National Post-Intensive Care Rehab Collaborative developed a tool called the Pickups tool, which fed into the rehabilitation prescription. And the Pickups tool is a post-intensive care screening mechanism to look at the needs of our patients to manage their functional disability. And in our first pilot of about 500 patients who survived critical illness, we looked at their workforce data requirements. And the average patient, or the median requirement of workforce, was 5 therapies. So almost every patient required physiotherapy, occupational therapy, speech and language therapy, clinical psychology, and dietetics, all of which are affected in some form by muscle wasting. And you can see from this graph, there is no difference between the COVID-19 related ICU admission and the COVID-19 related ICU admissions. So COVID patients have the same workforce needs for rehabilitation as non-COVID patients. We went on to examine this in greater detail, looking for patterns, and we used a network analysis looking at this, where the size of the node here represents the percentage need. The lines represent the correlations with other disciplines, and the strength of the lines represent the strength of the correlations. And the distance between the nodes represents the distance between the Euclidean space, i.e. how close these data cluster together. And you can see here, COVID or non-COVID, the pattern of needs is the same across patients who are critically ill and survive, i.e. COVID-19 survivors who are critically ill do not have different workforce rehabilitation requirements than those without COVID-19. So I think it's okay to say that actually there is no difference in functional disability between those with and without COVID-19. If we go on to look at muscle wasting, well, pre-COVID-19, if you look at the ATS document on ICU-acquired weakness, I think the systematic review of data from 2014 came up with the number of about 43% of patients on average had ICU-acquired weakness if you're admitted to intensive care. But crucially, the longer the exposure to mechanical ventilation, the higher the incidence of ICU-acquired weakness. And this perhaps we might go into a bit more detail when we talk about muscle mass. But if you think about that, 43%. Now, we're talking about normal intensive care patients where the mean ICU stay is about 4.7 to 5 days, and the median is about 2.4. And even the confidence intervals here are not that great, or the IQRs, sorry, are not that great in survivors between 1 and 5, and the standard deviation of about 8 days. And these trends have been stable over the years, length of stay and length of stay in hospitals have been stable. These are pretty happy that these figures are representative. So if we look at the COVID-19 patients in the first wave, the median length of stay was 12 days, with the IQRs being much, much wider, 5 to 28 days. So these COVID-19 patients stayed in ICU for much longer than the normal ICU patients, suggesting that they will have a greater incidence of ICU-acquired weakness and a greater prevalence of ICU-acquired weakness, which was seen in some of the early reports from Belgium. Average mechanical ventilation is 24 days. Again, and they came up independently with their own statement, these data indicate that there might be a price to pay for rigorous lung protective ventilation. So the increase in muscle wasting seen in the COVID-19 patients seems to be most likely related to the increased lengths of stay. It doesn't seem, from the weakness point of view, that there's any difference in patterns or in underpinning mechanisms, because there's no data to suggest that this is the case. And the increased lengths of stay and increased lengths of mechanical ventilations expose our patients to the same underpinning mechanisms that we see in the critically ill patients, and primarily that of immobilisation and inflammation. And this is a review written by Hannah Crossland from Nottingham, showing that looking at different slices of the cake, if you like, that however you look, whatever your insult, inflammation or immobilisation, you end up with the same metabolic and physiological endpoints of muscle wasting and abnormal metabolism. So all we're seeing is a change in the exposure length as opposed to new different exposures, we think, for muscle weakness. So at this point in time, unless new data arrives, we see no difference, no likelihood of a difference in the mechanisms behind muscle weakness in COVID-19 patients and those without. Going on to muscle mass and quality, we know that critically ill patients without COVID waste away rapidly. On the x-axis, you have time from ICU admission. The y-axis is change in muscle mass. And with increasing organ failure, you have increasing amounts of muscle wasting. So muscle wasting of 20% over 10 days if you have 2 to 3 organ failure, and 26 to 30% of 4 to 6 organ failure. And of course, this is again time dependent. So critically ill patients spend more time on the intensive care unit in organ failure, they will waste away further, which is probably what's happening to the COVID patients, leading to greater muscle weakness, greater muscle weakness. There's not a huge amount of data out there, I have to say, about actual loss in muscle mass in these patients. There is this paper from Italy looking at muscle wasting in obese patients. And overall, we're still looking over a 20-day period of something like 14%. So it does happen. These data, because they're sparse, might suggest to you that there's less muscle wasting in COVID-19 patients, but in reality, it's the lack of data that's the problem, as opposed to anything else. There have been preliminary reports of macrophagic infiltrations and myonecrosis in COVID-19 patients, which I know has captured many people's attention. But this necrosis and cellular infiltrate is not new. MERS-CoV has the same problem. These are data from the MERS-CoV outbreak earlier in the mid-2015, 2016, showing the same cellular infiltrate, which is CD68 positive, and some CD4 and CD8 positive cells. And if you go even further back, and if you look at the SARS outbreak that was in the early 2000s, if you look, this is a review of the post-mortem samples and muscle biopsies taken, and there were 13 cases of myonecrosis with macrophagic infiltrates. So it seems that these severe viral infections with acute respiratory failure do cause myonecrosis with macrophagic infiltrates, but so does critical illness. And these are our data in a general ICU population of 2013, where we found myonecrosis with a CD68 positive infiltrate in 40% of cases. So at this point in time, there are no data to suggest that the muscle mass loss or quality loss is any different in COVID patients versus non-COVID patients. And now we move on perhaps to some of the underpinning biology, and altered protein homeostasis is probably one of the major things we have to look at when we talk about muscle mass. So muscle protein homeostasis is a balance between muscle protein synthesis and muscle protein breakdown. And the critically ill patient has many, many potential factors to affect this balance. And we've shown in critically ill patients that in the first day of critical illness, patients have deep depressed muscle protein synthesis, the levels of fasted controls, despite the provision of adequate nutrition. And there's variable recovery over the first 7 days. Muscle protein breakdown, which is unaffected, is therefore greater than muscle protein synthesis, leading to a net negative balance, which continues over the first 7 days, leading to muscle wasting and therefore weakness. And this is mirrored by changes in the intracellular signaling pathways controlling both anabolism and catabolism through the ubiquitin-proteasome pathway and through NF-κ beta. This is my first ever talk, I think, to the Physiological Society, and I think it's important to bring up Mike Rennie. The late Mike Rennie was one of my mentors in muscle protein homeostasis and isotope work. This is his paper from 1985 in the British Medical Bulletin, where he talked about muscle protein turnover and the commonality of responses to injury and disease in muscle protein homeostasis, where human beings have muscle protein synthesis as a facilitative response to stimuli, and that muscle protein breakdown adapts, whereby you have an anti-anabolic stimulus, muscle protein synthesis drops, muscle protein breakdown drops, but not as much, giving you a net catabolic balance. So, and things that are anti-anabolic stimuli are immobilization and inflammation, the two things that affect our critically ill patients. So there's no reason to suspect that our COVID patients are not immobilized, because we have lots of data to suggest they're on the intensive care units, they're sedated, ventilated, and paralyzed, and that potentially they are inflamed too. And you will remember many of the discussions about hyperinflammatory storms and cytokine storms, suggesting that they might have some level of inflammation. So inflammation and immobilization both depress muscle protein synthesis, leading to altered protein homeostasis, just like every other critically ill patient. So again, there is no reason to suggest that there is any difference between the two. Lastly, we might look at bioenergetic failure and inflammation. So the critically ill patient struggles to use glucose, with hypoxia and inflammation affect pyruvate conversion to acetyl-CoA through the Pasteur effect, leading, and in fact, where we have diversion to lactate. And we demonstrated a decrease in mitochondrial beta oxidation, leading to a buildup of fat within the muscle. This is combined with a decrease in markers of mitochondrial biogenesis and of fission, like DRP1, leading to decreased mitochondrial copy numbers, and others. This is in keeping with data from other groups. This is some data from Frankie Duska's group in Poland showing that mitochondrial function decreases, especially oxalated phosphorylation, over time in critically ill patients. And all this leads to a decrease in ATP content. On the first day of critical illness, patients drop their ATP content. This is compared to controls. This is most seen or markedly seen in patients with chronic diseases such as COPD. And regardless of whether you have a chronic disease or not, over the first 7 days of critical illness, despite the provision of adequate nutrition, ATP content continues to drop, leading to bioenergetic failure. This is likely due to the hypoxia and inflammation seen in the critically ill muscle. This is a network analysis of cytokines and signaling molecules seen within the first 7 days of critical illness. And you can see in this cluster, hypoxic and inflammatory signaling clustering with markers of, with signaling molecules and keep on the anabolic and catabolic pathways. There are no data to suggest that the COVID patient is any different when it comes to bioenergetic failure and inflammation. So if we come back to this slide, I put it to you that the question of COVID-19 is not one of unique mechanisms. This is the wrong question that has been put forward. In fact, we should be asking a very, very different question. What can we learn about normal critical illness muscle wasting by studying COVID-19 muscle biology? One of the key problems with muscle wasting and muscle biology in the critically ill patient is that we have not established causality. You will find, no doubt, people in the audience that will argue that this is a primary mitochondrial disorder. Mitochondria choose to hibernate. Mitochondria mitochondria undergo hibernation as a result of external insults, such as inflammation. This is a conserving process. This is a process by which energy is released by muscle wasting. All these problems and hypotheses have a common link. We have not established causality. And now we have a group of patients, 6,000 survivors from the first wave, to be exact, who have undergone a new insult, okay, a direct inflammatory immune insult, which may result in PICS, the real PICS, the persistent inflammatory immunosuppression catabolic syndrome, as opposed to the catch-all or post-intensive care syndrome. And this is some work from the University of Florida showing the immaturity of granulocytes as they come through in critically ill patients who continue to be inflamed, and how that perhaps this immature immune system leads to persistent inflammation and progressive immunosuppression, and then into catabolism, into muscle wasting. And one of the questions that we put together with the groups in Florida is perhaps, where is the source of inflammation? Could it be the necrotic muscle that we see? Where is the source of the immunosuppression? Could it be that the macrophage infiltration into muscle contributes to progressive inflammation and progressive immunosuppression? Certainly, long-term inflammation is a problem. We know from the recovery program of work from Scotland that these data, this is from David Griffiths, showing that 3 months after ICU discharge, there are still a significant proportion of patients with raised CRPs. And these CRPs are associated with poor mobility and poor function. We know, taking you back to this, that patients who are critically ill, who have been ill for at least 7 days, have intramuscular inflammation and hypoxia, and it's likely that these COVID-19 patients also suffer from the same intramuscular phenotype allowing us to investigate the biological effects in greater detail. And to understand that it's not just physiology and metabolism that underpins critical illness muscle wasting, but immunology and immune dysfunction that likely does so too. And this is, for me, the third and last bit of physiology that we need to integrate into our understanding to understand how we treat and manage critical illness muscle wasting. Thank you very much.
So our thanks to Zudin Puthucheary for that very thorough and engaging presentation. And we're going to reserve questions and curiosities for the panel discussion after our second speaker. So our second speaker is Gladys Onambele-Pearson, who's a reader in human muscle tendon physiology at Manchester Metropolitan University, and she leads a research themed group on human exercise and environmental physiology. So Gladys, if you're ready, if you could share your screen and take it away.
Thank you very much, Steve. I am starting to share my screen. So good afternoon, everyone. I have my timer so I don't go over time. So I'm really grateful to the Physiological Societies and Intensive Care Societies for the invitation to speak at this very interesting conference so far I attended yesterday. So my take on this topic that came from me is from the point of view of a sports scientist, looking at how exactly this situation we are living through, the COVID-19 pandemic, has relevance to the world as a sports scientist and an in vivo human muscle physiologist. So I will start with a few reminders about where we are and the kind of clues I took from what is going on with COVID to infer that there is likely to be an involvement of the musculoskeletal system, and therefore we could be looking at strategies that are non-pharmaceutical to hopefully helping with the rehab and recovery of patients who have had a contact with COVID-19. So a few reminders. So during this situation we've had worldwide, there has been a number of lockdowns or isolation periods, however we want to call them, where people have had their normal amount of ambulation outside of their own local environment limited somewhat. What we also know, and it's a reminder just for us, is that COVID-19 who have required intensive care were more likely to be part of our older population. And it's particularly interesting for me because all of my research is mostly on sarcopenia and aging related frailty. So the fact that we were particularly looking at this population to be especially and more stringently in self-isolation meant to me directly that we are likely to have some consequences that may be beyond contact to COVID-19, but linked to the fact that we are restricting movement of the population. So there is also the fact that the pandemic is directly causing morbidity and mortality in those that it's affecting. But what we also know is that those who have been in contact with the virus in some form or another are likely, at least 10% of them are likely to show symptoms for over a week, and therefore there is this long-term exposure to frailty, or what I call frailty here in terms of decreased physical functioning, that is long-lasting and therefore impacting on everyday life. So what has been done and what do we see so far? So more statistics relating to the overall physical functioning limitations related to COVID is that 24% of the patients will have a 24% of the patients will have a 30-day mortality rate, and 50% of the people who've been in contact with COVID-19 will have some kind of pulmonary complications. So this is a very important issue. Several other clinical groups that are not necessarily linked to COVID, such as cancer patients, have had their data looked at, and it also shows that patients with sort of inelective clinical pathways also have poor outcomes as much as whether they've had COVID-19 or not, related to all of the logistics issues that we had with COVID. So what has been going on from my colleagues in primary care, sorry, just going back too fast, is the idea that a lot of the precautions that are being looked at when we look at the treatment of COVID patients, whether they've had sort of a stay in hospital or whether they were treated in the community, when I was looking for all of the key words, a lot of the words were related mostly to the pulmonary, cardiovascular, and in some cases renal nephrology kind of approaches to monitoring, rehab, and treatment. But I couldn't see a lot of the words that would link to the musculoskeletal system or overall function. And that struck me as an interesting thing to dig further into. So why is that particularly interesting? As I said before, there is a group of patients, those who have been in touch with the virus, that carry on with having a poor sort of life prognosis for a long time. And for many of them, what I would also found particularly interesting in a point of view of musculoskeletal scientists is that there are many factors, many symptoms that people are sort of recording as having in the long term, that seem very much linked to the musculoskeletal system. When we look here, that there are some that are reporting Sjogren's syndrome, there are some who are reporting long-term fatigue, muscle pain, and somewhere down here we have some reports of joint pain as well. So these are again further clues that the musculoskeletal system is very much involved in the sequels or the symptoms of COVID, whether current or long-term COVID. The previous speaker made a very good point of saying that there is this functional deficit that is seen in the patients who have recovered. And in the discussions yesterday, again, many of my colleagues who presented were talking about the fact that many patients, even at the point of release out of hospital, are still showing very elevated levels of dysfunction. So the problem is one to consider. The issue that I also find of particular interest is that while we seem to have growing data on the patients who have been involved with attending hospitals and potentially being in intensive care unit on sort of the trajectory of their recovery, there isn't as much data that is forthcoming for those patients who were treated or remained in the community, either because they were asymptomatic or they had mild enough symptoms that they did not require, or decided for themselves that they did not require attendance to a hospital. And these are most likely to be the greater proportion of the people who may present in the long term with long COVID, excuse the tautology there. So what the question that I'm thinking about relating to the link to musculoskeletal health is, how can COVID influence these things we're seeing with the decrease in functional recovery? When I speak of function, I speak of the motility, the mobility MSK function. So is the link to the MSK system really just because of some kind of long-term respiratory consequences, and so the musculoskeletal system is just a secondary target to the disease, or is there a direct impact on the musculoskeletal functioning itself? Are there specific target points for the COVID-19 itself to be impacting on the musculoskeletal functioning? Are these targets directly through the musculoskeletal functioning? I don't know how to hide this put this mark here, or are these related to the musculoskeletal system of those people who are already quite frail or at risk of frailty, being much more likely to become deconditioned because of the fact that they already are sort of subpar in terms of their fitness level. So we would probably look at someone who's older, someone who's obese, whether it's obesity or sarcopenic obesity, or someone who has a chronic disease. Is it just because these particular group of the population is already at a functional threshold that the COVID-19 is having an effect on their functional ability, or is there a direct link to musculoskeletal physiology? So I believe that there is a case to make that to make for MSK to have a direct link and a direct sort of link to how COVID-19 is impacting on people in the acute and the chronic term. So this is because from all of the symptoms that people are reporting with the COVID, we can see that all the body systems are being affected. And because of this, I wanted to call it cytokine storm, but a presentation yesterday described it as potentially a cytokine drizzle in as much as it's not necessarily that it's particularly elevated compared to anything else, but it is still measurable and impactful. So what we see is that beyond the respiratory system, 50% of the COVID-19 sufferers are describing things that would be impacting on their ability for habitual mobility. So there's weight loss, whether this is skeletal muscle or fat loss is an interesting one that needs to be looked at. There is lethargy and there is myalgia, even in the mild cases. So these are all things that are potentially linking, to my mind, to musculoskeletal system to being an important consideration in the treatment, short-term and long-term for COVID-19. And what we also see is that a fifth of the patients who have reported in hospital and have had some kind of blood biochemistry test is that they show some signs of muscle damage. There is signs of rhabdomyolysis. There are signs of increased creatine kinase. I have heard increased creatine, and there are signs of elevated potassium, etc. All of these things that will be directly impacting on the musculoskeletal system. There are also reports that the fact that cardiomyopathy occurs means that any muscle tissue is likely to be a target for COVID-19 and therefore needs to be looked at. Another point of interest that I found on the internet is that it's a report by Public Health England on the wider impact of COVID-19 on health. And the key home message that I took here that is speaks to me as a sports scientist was the idea that at the early stage of the first lockdown, 1/3 of adults in the UK were reporting doing 30 minutes of physical activity 5 times a week, which is the normal and standard recommended physical activity for adults. However, looking at the data later on in the year, by August, so a mere sort of 4 months, if that later, these had decreased to this proportion of adults who do meet the physical activity requirements had dropped down to 1/4 from 1/3 before. And this is a particular interest because for something to have such an impact, for any kind of clinical issue to have such an impact, it means that not only those who have been in hospital with COVID or have had mild cases of COVID, but the general population as a whole is having an impact, be it indirectly, of the COVID-19 through the physical restrictions that we all had to endure. So the way in which one could again describe the musculoskeletal system as having a link to COVID-19 is through the observations from the SARS pandemic of 2003, where they took some objective measurements of physical functioning and physical capacity, and they found that the people who had been exposed to SARS had decreased hand grip strength and decrease in their the total amount of distance, the total distance that they would cover in a 6-minute walk performance. So again, it shows physical deconditioning with a COVID viral infection, be it in this occasion, the SARS-CoV-1. So another way that the musculoskeletal system may be directly impacted on by the COVID-19 is because the MSK, the skeletal muscles, do have ACE2 angiotensin converting enzyme 2 receptors and also serine protease as well. So these are direct ways by which the COVID-19 infiltrates the different tissues that it goes to affect, and the fact that we do have those systems, on skeletal muscle means that we are likely to see skeletal muscle as a direct target to COVID-19. And as others have said so far, there are many pro-inflammatory cytokines, the markers of skeletal muscle breakdowns that are elevated in COVID-19. So from the interferon gamma, IL-1, IL-6, tumor necrosis factor alpha, they all seem to be increased in COVID-19. But as my previous speaker, as Zudin said, we cannot say that the increase is any greater than any other sort of bacterial sepsis or any kind of long-term inflammatory condition. Nevertheless, we can say that inflammation is increased in COVID-19, and that has likely an impact on skeletal muscle function and structure. So why is this important? So looking in the bigger picture, so regardless of the direct impact, but also the lifestyle impact of COVID-19 and how that may lead to physical functioning decreasing, sorry, checking my timer, we observe studies that I've done in my lab with and others have done as well, that older adults, so when I speak of older adults here, I speak of 65 years old and 65 and older, will tend to spend a greater majority, 65 to 80% of their waking hours, so that's around 16 hours per day, performing sedentary behavior. So this is necessarily sitting or standing without much movement or any movement that raises the metabolic demand of that activity above the resting levels. So sedentary behavior is an interesting one, and it often tends to be conflated. Presence of sedentary behavior tends to be conflated with absence of physical activity, and I will propose to you that these two terms are not interchangeable, because sedentary behavior presence is seen to have a separate and independent impact on the physiology compared to physical activity. So when you objectively measure sedentary behavior, so amount of sitting, so we can see that sarcopenic obesity increases, so the infiltration of fatty tissue within skeletal muscle and the linked asthenia to that sarcopenic obesity increases with sedentary behavior on its own, regardless of presence of physical activity, but this is just with high sedentary behavior being present. Bone mineral density decreases with sedentary behavior, metabolic risk factors increase, so lipase activity decreases with high sedentary behavior, and several things like triglyceride levels, etc., also increase with sedentary behavior, regardless of concurrent high physical activity when the person isn't sitting. Overall human frailty, mortality, especially in older adults, is seen to increase with sedentary behavior. So whilst the governmental plans to have 5 minutes to have to isolate people to ensure that we do not spread the COVID-19 were necessary, the issue is that it would have tended to exacerbate the level of sedentary behavior, and this is an issue for everyone, but especially for those people who are already in a state of sort of clinical borderline for physical independence. So this increased sedentary behavior would have been an issue to the musculoskeletal system of anybody, including those people who have not necessarily been in contact with the virus. So what so now selling you the idea, and I'm not sure that anybody needs to be sold the idea, but certainly selling the idea of physical activity and physical activity being important for health. This is a picture from a group by Mindley et al. In JAMA, and they were reporting the mortality rate as a factor of the number of steps, walking steps that a person takes every day. And they also looked not only on at the number of steps, but they also looked at the cadence, so the intensity of that steps, whether people were taking more steps per second or less step. What was interesting is that cadence is not that important. So the intensity of the effort is not that important in terms of changing your mortality risk. However, the number of steps per se seem to be what is more important to consider. And this is where they created this sort of decreasing curve, whereby one would probably propose that at 10,000 steps, you've reached your optimal level of mobility to reduce your mortality significantly, and by increasing further than that, there are no further gains. And this is probably very important, especially for older people, the fact that you don't need to go all the way to a very high number of steps. So, and another thing to consider is that not only is physical activity per se important, but the fact that sedentary behavior is also an important factor to consider, and how one accumulates that sedentary behavior, whether one is being sedentary for a big chunk of times, or whether the sedentary behavior is sort of broken up by periods of physical activity. And it looks as though certain things like, for example, glucose tolerance, insulin response are much more negatively impacted by a long and unbroken period of sedentary behavior than if the same amount of sedentary behavior would have occurred, but would have been broken in shorter time stamps. So for me, it was good as a sports scientist to see the whole population in the UK get interested in the fact that physical activity is important during lockdowns, from newspapers to exercise equipment providers showing and telling to the population that we need to move even in this period of being isolated, and having the level of movement that we can make sort of a lot less intense. However, the message was incomplete from my point of view, because the majority, in fact, all of these texts were mostly in terms of asking people to move rather than asking people to not sit down. Sorry, looking at my time here. So there is also the issue that when we asked for any population, whether they are clinical population or just a group of people who want to improve their physical activity to move, is that they are limited in their efficacy because a lot of people do not enjoy vigorous physical activity, or in some cases it's to do with the logistics of accessing to the club where they need to go, or having someone to go with. So for those reasons, physical activity in the frail population or our risk population, such as those our older population that was very much restricted during the lockdown, is going to be a major barrier that will stop them from maintaining the level of physical activity that we need. So this is an issue. Initially, that's how it could be looked at, that the fact that people are not likely to carry on medium to vigorous physical activity for a long time will be an issue, because essentially we are not able to revert many of the clinical conditions that occur from the lack of significantly high physical activity. The other thing that we also need to look at when we consider medium to vigorous physical activity is that in some cases, particularly frail people and older people, in fact, there is a negative immune response to particularly high level of physical activity. So this is another reason why maybe we should look away from necessarily asking anyone to, so that was my timer, to do hard physical activity, medium to vigorous, but also look at other ways. In any case, this work is showing us that exercise that is prescribed is only something like 15% of our physical daily energy expenditure, and therefore it's really what happens in that time of the day when we're not physically active that has more of the metabolic demand and physiological impact on the body. So given this low palatability of medium to vigorous physical activity, we need to be looking at other kind of physical intervention that will be much more likely to be maintained in the long time, much more likely to be palatable to the people who are affected. If lethargy is one problem in the patients with long COVID, the last thing they probably want to do is a hard class of body combat, for example. So I'm a PhD student, did some work on looking at implementing what we call the sedentary behavior fragmentation program. This is the idea of a program of 8 weeks that he gave to a group of 30 older people, whereby they were not being asked to exercise, but they were being asked to not sit for a certain period of time. So some people were asked to do some very sort of typical physical activity training, and there was a group of control, and there was a group who were not allowing themselves to sit down during their waking hours. So the screen is sort of, my pictures are slightly hidden here. I don't know how to get rid of them, but essentially the results were very good. Palatability and adherence to the program was good. We used a 3D accelerometer to ensure that the prescription of sedentary behavior fragmentation was adhered to, and we found that several measures of physical functioning were improved, from grip strength to gait speed to postural balance. We also found that when we were looking at potential markers, so physiological modulators of the responses that we'd seen, we looked at muscle volume using a combination of DEXA and B-mode ultrasound to quantify physiological cross-sectional area. Long story short, what we did find was that the sedentary behavior fragmentation, which is essentially exercise by stealth, you're not asking people to exercise, you're just asking them not to sit for so long, is very effective despite the very light intensity of physical activity that is required. We call it light intensity physical activity. We just ask them to stand up and maybe shuffle from one leg to the next. So what is interesting is that with physical activity, we may have sort of compensations that may be pro or con the overall outcome that we want to see. So what we found from the literature is that there are papers that were already recording the idea that the exposure to COVID-19 and the sort of lockdown and restrictions and that the population worldwide was not only having an impact on the physical activity levels I mentioned earlier, but it was also having an impact on the dietary habits. In some cases, it was positive and people were at home cooking and baking, but in many cases, what was found was that diet took a little bit of a, the COVID-19 took a little bit of a toll on diet. So 32% in the study of participants in the study by Cheng Zhen, who had a normal, whatever it's called, normal weight before the pandemic, and 32% were overweight during the pandemic, with 34% who were obese in this sample population, they found that the weight gain was seen by all the groups and especially those who were obese. So this is again showing a secondary effect of the pandemic that was not potentially anticipated. And another study also was giving us indication that the weight gain may not have been the type of weight gain to just skeletal muscle increment, but potentially more of the adiposity increased because the type of foodstuff that was being consumed was more sort of snacks rather than healthy foodstuff. So we again did an analysis to look at how this idea of sedentary behavior fragmentation would impact on spontaneous dietary behavior. I'm going fast because I've run out of time. So we were plotting, because it would have been quite tedious to look at each of these different elements on their own. So we plotted the data for all of the key dietary components that are linked to either bone health or skeletal muscle health. We plotted them before and after the intervention, having not given any of the participants advice on what to do or not to do, just to see what kind of spontaneous adjustments to their diet people have. And the quick picture that you can see is that people who move from being very sedentary at baseline, this is the blue map underneath here, really interestingly changed the pattern of diet very drastically. And when we separated that diet for things that are beneficial to skeletal muscle or to bone, again we saw some very interesting pattern of self-selection of better dietary component compared to before. What is reassuring is that many new recommendations are taking more that idea of decreasing sedentary behavior regardless of physical activity being present seriously. So there is this report by the NIHR, Age UK, Later Life and Manchester University that specifically made allusion to the idea of sedentary behavior needing to decrease. But there are still very much reports where the idea of physical activity being seen as interchangeable with sedentary behavior is still being used. Very quickly, summary points for me is that we still need some work in understanding whether the frailty, the musculoskeletal frailty linked to COVID-19, particularly for those patients that have been directly affected by the disease, has a different pathway to the frailty that we see with any other kind of highly inflammatory condition. The take-home message from my point of view is that we need to recommend that we want to decrease sedentary behavior and increase physical activity at the same time. Either or on its own doesn't quite work very well. Because I'm done with time, I just want to thank my team, my PhD students, and I'm ashamedly saying that I need to find jobs for these two if anybody has any jobs, and my colleagues at MMU, Liverpool, John Moores, Nottingham University, KU Leuven, and University of Northampton. That's where he is. Sorry, I ran out of time, but I think I've just finished with a couple of minutes to go.
Thank you very much, Gladys. That was a very, very thorough story that you told us there. I was particularly interested in the notion of smuggling exercise into people's lives by some sort of behavioural Trojan horse and taking away their chairs. So yes. Particularly interesting. So for the rest of this session, we have a panel discussion. We've already got some questions which have been sent in by the audience, and we're joined on the panel by Carolyn Greig, who's a physiologist with an interest in design and conduct of exercise and nutritional interventions to maintain muscle health in the older age group, which is obviously relevant to this discussion, and also Janet Lord, who's an inflammation biologist with an interesting aging of the immune system and physical frailty. So welcome to Carolyn and Janet, and obviously we've got Gladys staying with us. So if you'll permit me, we have questions which have come in from the audience. Sadly, we don't have Zudin with us, but one of the first questions was around the variability of the data which Zudin presented, and particularly whether there was any explanation of the variation in response for, I guess, different conditions following periods of bed rest. So obviously there's bed rest where you're just lolling around in bed is one thing, but if you're actually ill, it seems quite different. And I know there was a lot of work done on as part of the space program for prolonged immobility, wasn't there? So are there any answers, do we think, in these other fields that might help us explain the variability in response to bed rest, in inverted commas, which is a slightly old concept now in most hospitals?
I'll probably chip in there. I think Carolyn did an answer to this one. I think there certainly is. And in Zudin's talk, you know, he brought across really that you've probably got two big signals in there, inflammation and immobilisation. And if you've got the two together, for example, it could be that the patient is a major trauma victim and has tissue damage to give the inflammation, or in the case of COVID-19, an inflammation arising from the immune response to the infection. So when you've got those two together, they're certainly going to be worse than immobilisation alone. But I think the other thing that comes out is, you know, the baseline of the patient before they end up in ICU. And there's a very interesting paper that came out of the analysis of UK Biobank data, showing that when they looked at the biological age of the subjects and then followed them through the ones that did develop COVID, interestingly, the ones that had severe symptoms and poor recovery were 10 to 14 years older biologically. And you could see there'd be lots of reasons for that. You know, they may have low physical activity that's accelerated their aging, or, you know, or other factors such as obesity. So I think the baseline that the patient starts from will be important as well.
Yeah, if I could add to that too, that, you know, we're talking about older people here, and the mean age of our COVID inpatients was what, 73 years old, and some of them may already be close to the thresholds that Gladys mentioned, or may even have crossed thresholds. And so they're already quite highly deconditioned, and therefore that additional immobilisation insult combined with the inflammatory insult could make for quite a poor outcome.
And just a supplementary from me. So in the space program immobility programs, did they see people developing inflammation in response to immobility, or not so much?
I'm not so sure, actually. I don't know whether
Gladys, do you know?
Gladys may know.
I'm aware of the work of Marco Nerici, and he did quite a few bed rest studies and limb immobilization, particularly the lower limbs, whereas I've done some limb immobilization on the upper arm, and for sure there is an increase in inflammation, even on, so we're taking healthy and non-injured university students, but their profile also shows some, you know, an inflammatory response that actually would translate to it becoming an issue, and we're having to provide rehab for only a 3-week immobilization. So it's interesting that just that factor of not moving is a sufficient trigger.
Yeah,
Okay,
you would predict it would be, Steve. So, you know, if they were immobilized as they are in the space simulation for extended lengths of time, and the muscle isn't moving, not producing myokines, you would predict that they would have raised inflammation. But they must have measured it, but I just can't remember.
Yeah, so muscles are designed to move, aren't they?
Exactly.
Okay, let's move on to the next question. So it says, I guess in response to Zudin's conclusion, although there appears to be no difference in the consequences of COVID and non-COVID related bed rest, do we know if there are any differences in the ability of the body to deal with the mechanical and biochemical disturbances caused by exercise? So I guess to rephrase that slightly, so if we looked at two groups of people, does their future look different in terms of response to rehabilitation and an exercise program? I guess we probably don't know that yet, do we?
I don't think we do. There is a study I found, a training study. So this is exercise training, which is a particular form of physical activity in patients who'd survived a SARS assault in the early 2000s, and the muscle responded to training. It was mixed aerobic resistance training, improvements in muscle function and strength and functional ability, etc. However, the average age of the participants in that particular study was late 30s. So, you know, again, they may be starting from a much higher baseline, as Janet mentioned. So, you know, you can still respond seemingly, although, you know, that's, you know, when you add that inflammatory insult as well, or indeed if the immobilization also contributes to that inflammatory insult, you know, how responsive is the muscle, and can the muscle recover? How long does it take? And we don't know that.
Okay, and there's a related question from one of the audience members. To what degree does the level of habitual exercise and the mode of exercise undertaken prior to illness impact on post-COVID symptoms and degree of debilitation or debilitation?
And again, I think if you're starting from a better baseline, then you'll, you know, if you're nowhere near the frailty threshold, then you'll have a better chance, you'll have a better recovery from the immobilization and the inflammation, and your immune system, you know, we know in regular exercises that their immune system is better. So if they were habitual exercises beforehand, they should actually have much better outcomes.
Okay.
Yeah, I completely agree with Janet's point. I think it's all to do with your physiological reserves. The more you have, the less steep that decline you see under immobilization or a sort of a inflammation sort of storm. I keep calling it storm, but people call it a drizzle. But certainly what seems to be important is your starting point for sure, because at least the phenotypic expression of your decreased function will be less visible compared to someone who already was at the threshold of what they can do. And it is a shame, and it's probably one of the limitations of the studies that go on at the moment. They tend to be carried out on already healthy people. So anything that we see will be limited by the fact that we're starting with people with a high physiological reserve, and therefore the rate of what we're seeing changing is not so drastic. But at the same time, for rehab, we have the rehab studies tend to be easier to achieve because you're actually promising to get people better rather than the deconditioning studies in people who are already at a threshold. But yeah, completely agree. It's your physiological start point, really.
And so can I just ask a question? I mean, in my part of London, it's a bit like a training camp. Every day there are lots of people out there running, cycling, not using the river anymore because it's banned under current restrictions. But the level of exercise in our local community has actually, if anything, gone up because lots of people are able to work at home. So if you're going to spend the entire day on Zoom or Teams, which certainly many of us have, then to maintain sanity, you need to do something else. But it's relatively easy for that part of the population. You can't build a car by Zoom, for example. So do we know anything about the sort of spatial distribution of this exercise deficit? I mean, are there parts of the country there where it's simply harder to get the needle to shift in terms of population exercise?
I would say I think it's the only data I've seen on that, Steve, is more to do with the age profile. So, you know, the ones you're seeing around are likely to be young or middle-aged, and where it's hit hardest are the older groups, again, who probably had the lower reserve anyway. So that's the only data I've seen. It's more an age split rather than a geographical split.
Yeah, okay, well, that makes sense. Although we do see some older people getting out of the house and exercising very early in the morning, because obviously they're sort of still trying to isolate a bit.
Yeah.
I guess the other thing, I mean, for us in our hospital, lots of the COVID patients we have on ITU have significant chronic morbidities now, particularly renal failure for us. And for them, obviously lots of their week is dominated by dialysis sessions when they're at home. and then a day feeling pretty rough, having spent several hours on dialysis. So it's particularly difficult for these populations, but people who have comorbidities, to envisage them taking part in an exercise program. And that's certainly something which I've seen in our follow-up clinics, for example. So we have younger people who are itching for permission to get back to physical exercise, and although obviously at the minute lots of us, the gyms etc. are closed, but older people who have prior problems with arthritis, or perhaps they're a bit on the large side, then the idea that they can go back to some hard physical program is extremely challenging. And I remember running a focus group at the faculty of intensive care with a group of patients and family members years ago, and we got a real kicking about motivation, because it was something that perhaps we hadn't really focused on sufficiently. And the patients and their families said, well, look, what you have to realize is that actually for a lot of people, it's not just presenting them with a physical rehab program. Then you actually have to wrap that round with appropriate motivational training. Otherwise, people aren't going to push themselves to maximum exercise. I think that's something that perhaps in some of the studies that we've done, certainly in critical care follow-up, we slightly underestimated the role of motivation. To move on to question 4, which we've got here from audience, was about the increased therapist workforce available, and I think I think the therapy workforce does seem to have grown. It says, does the increased therapist workforce indicate a case for more therapists for non-COVID ICU patients, or was the response an overestimation? And so what do we think? I mean, my sense as an intensivist is that the pattern of therapy provision actually throughout the country is pretty patchy, and there are some places where it's much better than in other places. But presumably this is a sort of thing. I'm interested in the role of exercise therapists, if people from non-conventional professional backgrounds, and whether they are in a position to help. Can I ask all of you whether there is any potential downside in asking people to exercise at a point in their recovery where they're perhaps physiologically not ready to push yet, to use a simple term? How does one calibrate the start point of hard physical training?
I guess if we're focusing on muscle health in this session, so again, a lot of the data shows there that if you can just start them, I mean, Gladys has talked about breaking up sedentary time, but very simple resistance exercises I think are a good point. If you're going to really think about the muscle, then not challenging them too much with any heavy aerobic to start with. And that also I think would be not, and you talked about motivation, Steve, and I think sometimes even the thought of exercise can just put people off totally, whereas perhaps a very simple resistance exercise program to start with and reducing their sedentary time can get them to feel better. And Gladys's work certainly suggests that's the case.
I agree. The idea, I think it can never be too early. This is only for the musculoskeletal system, because it's one that sort of goes into that negative loop of the less you use, the less you're able to do. And again, if you come from a period of having been immobilized for an extended period of time and being quite frail, the gains will be felt much more acutely, and I think it contributes to the motivation, because the little you do has such a big difference to your capacity later on. And I think that's why I particularly like the idea of exercise by stealth, because working with older people, we managed to, and we also did a study actually on cardiac rehab patients. We had 200 patients from the Mid Cheshire Hospital. Again, these were people who traditionally were not into exercise, but they were better able at doing the sedentary behavior fragmentation and reverting their condition than any other time when we actually paid for them to attend the local gym. So there was no cost associated with that, but the group that had what I call traditional exercise was much less likely to stay with the program for the 12 weeks than the group who didn't realize they were doing exercise. We just said, if you're watching TV, keep watching TV, but they had the monitor. When it rings, just stand up and move your arms. We asked them, that we didn't ask for actually exercise, so nothing that would take you beyond your sort of make you increase your rate, your breathing rate. We're actually asking you to just not sit down. I think that idea of combination of motivation, palatability, but also incorporation into lifestyle. If you're not asking someone to leave home to make a time for this exercise, it's a lot better. So what we're asking is, for every 30 minutes of sitting, stand up for 2 minutes and do something. So they're still listening to the TV or the radio or in their social group. So they're not having to make a specific time out for this. And the fact that we have measurable bone and muscle and functional improvement with that level of load, I think it's very promising. And I think it could be implemented in hospitals, because there is no specific need for equipment. Just don't lie down. If there is a capacity for standing up every 30 minutes for 2 minutes, only 2 minutes, I think it's a powerful message, particularly in the frail.
Okay, that's right. That relates to another question that we've had, which says how early do patients receive rehabilitation in the ICU? And the general trend now is, of course, to, as soon as patients are physiologically somewhat stable, is to try and get them out of bed. I think the thing that we feared as intensivists was, and I think it's probably is true, is that the number of patients that we have receiving neuromuscular blockers for prolonged periods of time exceeds our normal experience. So we have patients who are having to ventilate in a prone position for long periods of time, receiving neuromuscular blockers, so their muscles are absolutely static. And that was something which was really contributed to our anxiety. But it's but the general tendency is that when people are on a recovery threshold trajectory, is to try and get them out of bed as soon as possible. Next question: how severe does the disease have to be for inflammation levels to be increased and potentially affect muscle tissue? So is there some sort of notion of dose response? Does the severity of inflammation actually have a bearing on the level of ultimately muscle wasting, muscle loss?
Yeah, it's a very, very interesting question. So we see with, if you compare young and older adults, that there is an increase in their systemic inflammation, and it's anywhere between 2- and 4-fold increase of what you would see in a young person. And that's almost certainly, like, you know, it's due to lots of things. So it's due to increased physical inactivity, it's due to increased adiposity, it's due to some of the basic aging mechanisms, but that's entirely preventable if people stay physically active. So we've done studies in older adults that have stayed physically active and they don't experience this inflammation. So that's one thing, that's what it's called inflammaging. But other diseases, lots of chronic diseases, you know, rheumatoid arthritis, inflammatory bowel disease, they'll have levels of inflammation much higher than that. That can affect the muscle. So yes, it doesn't have to be massively raised. It's often the chronicity. So you can get this, you know, raised level of inflammation for months, and that will then damage the tissue.
Yeah. So there've been a number of studies which have looked at essentially non-settling inflammation after critical illness.
Yeah.
Haven't there? Which I was struck by some of the work from the Edinburgh group, where I think this started with Anthony Bateman a long time ago, where they looked at the CRP in people in follow-up, and they were actually interested in anemia. But some of the most interesting findings in the study was that the CRP in a group was elevated out into recovery, and those patients actually had high level. They were much more likely to be anemic. They had high levels of endogenous erythropoietin. They were erythropoietin resistant. And it actually translated into significant impairments in quality of life and functional recovery. It was a very striking finding. What was also interesting was that they they found that they couldn't get the 6-minute walk test to work in that particular patient population. So even though it was, lots of the patients were relatively young, it just seemed so unappetizing to exercise for 6 minutes. It was just too much, and they had to default to using the hand grip dynamometry thing. So I learned a lot from that study.
Again, an age impact, Steve, because we've done a study comparing critically injured patients, military veterans compared to civilians who were both young and old. And it's interesting in that the military guys, they all lost muscle at the same speed, no matter what age they are and how fit they were, because the insult was so extreme. But then at around 8 weeks post, they start to recover. But the thing was, the older patients never got back to any sort of baseline. So they didn't recover fully. They've got this anabolic resistance. And interestingly, their inflammation stayed raised. And we followed them for months afterwards, and it was still raised. Whereas the youngsters had got it under control and came back, and their CRPs were fine 6 months later. But the older patients, it wasn't. It stayed raised.
So can exercise drive the CRP down in younger people?
Yes, definitely. Yes, quite a few studies showing that. And old as well. Like I said, in these 55 to 80-year-olds who were exercising, they've got none of this increased inflammation with age. Did really well.
Okay, good. A few more questions. For Gladys, are you aware of any attempt to quantify the total impact of social restrictions, particularly lockdown, on mortality arise from increased sedentary behaviour? Have we been able to measure this? We haven't been able to measure that yet. Okay, but it's obviously everybody's anxious about, aren't they?
Yeah, it's definitely something that we've written a grant to do. We're working with the people at the Northern Care Alliance to try and get some data on exactly whether sedentary behaviour or lack of physical activity had the two married up during the lockdowns. But
I guess the other thing is that if you take older people and you reduce the level of sort of cognitive stimulation as well, that might have a synergistic effect. So I know my mum, who's been pretty much stuck at home, she's like a lot of older people, struggled to negotiate the whole thing, and has actually, if anything, found it harder as time's gone on. What about wearable tech? One of our audience members asks us. So any expertise in the use of wearable technologies in rehab following critical illness and motivation? Do we have any evidence yet that this can leverage recovery for people?
Wearable tech, I think it's still quite new, and it's all being investigated on. We tend to use, in my lab, we tend to use 3D accelerometry to try and look at people's movement in real life. So we're working with some orthopedic surgeon to look at the level and quality of movement before and up and after, and recovery and all that. However, what would be more interesting, and we're looking at, is the idea of wearing the sort of EMG suit, because we want to look at the intrinsic electromyographical signature of the muscles and how they're coordinated and the intensity of the signals. But this hasn't been done. Whenever we try to make rehab monitoring a lot more objectively quantified, it's met with, I don't want to say resistance, but because of the logistic demands of doing that kind of work, it's never really taken up by a hospital, because we're asking for someone to collect that data. We've tried as a scientist, we tried as light things as possible, say, well, can we have some saliva samples, or we're going to measure some cortisol, etc. But even collection of that was not quite successful. So it works in the lab, but I don't know Janet's and Caroline's experience, but I don't find that to translate any kind of wearable in clinic for adoption is working because of logistics.
Yeah, I think you're right, Gladys. I think, there's a difference between doing our sort of our lab-based studies, or even our community studies, where you can use wearable tech, incorporating it into behavior change interventions that do seem to be effective. I think it's when you try and take that out into this kind of situation, that it might be more difficult. And I think I'd just like to pick up on an earlier point, Steve, where you talk about older adults and cognitive decline and physical decline being at home. I think being at home is a big problem, and those older adults who can adapt, and those COVID survivors who are older adults who can adapt, will do better than those who can't, i.e., or those who've already got some pre-existing inflammatory condition, or some mobility issues or cognitive issues. And they're the ones that are going to have difficulties with the wearable tech. They're the ones that are going to have difficulties accessing the right kind of activity classes on the internet, etc. Those who can adapt will do and will do okay. But it's the ones who can't, who are the most vulnerable, who will suffer more.
Yeah. My colleagues in upper GI surgery have got a program to accelerate recovery after major surgery with using sort of Fitbit step targets and these sorts of things, which seems although it's using technology, it's sort of modest in overall scope, but seems to be having some useful effects. In the last few minutes that we've got, are we setting ourselves a huge problem with lockdown, working from home, increasing sedentary behaviour permanently in the younger generation, the younger working population? That's an interesting social medicine question, I think. And are we permanently changing some parts of society to a more sedentary existence? And I guess we don't yet know that, but it must be a risk in some parts of society.
Oh yeah, well, the Physiological Society commissioned a survey, a YouGov survey, and over 20% of older people, their physical activity has declined as a consequence of the last few months. So it's it's at the moment it's not looking great, and all those people that you see outside in London, maybe they're younger people, but older people, and as I said earlier, the ones who are having trouble adapting are definitely going to become more sedentary, and that's going to have longer term consequences.
Yeah, okay. Absolutely. And the idea as well of, when we had, I think it was in France, but in some countries there was a limited time period that you were allowed to, sorry, I'm half French, so you were allowed sometimes to just go out for an hour. And the issue is that doing your exercise for 1 hour for that day and then sitting down and being, well, generally sedentary the rest of the time, the amount of physiological sort of deleterious sort of cascades that is being created is not reversed by that 1 hour of exercise. And that's where the danger is. I've put in my hour of cycling, running, whatever it is, but the rest of the day I'm on my computer, sitting down, and I mean, I'm standing, I'm not sitting down, but certainly it's the idea of forgetting about the remainder of the day, having done physical activities, where we are failing to realize that it's even more of a problem than not doing physical activity. It's the sitting, and the person who asked the question has hit it on the nail, really.
Yeah, but I think there's some lessons there for all of us, probably, aren't there? And the last couple of questions I don't think we probably answer. So, are rates of critical illness, myopathy and polyneuropathy consistent with length of ICU stay in COVID patients? Well, there's intuitively, there's like to be a relationship, but I'm not aware that anybody's published any formal mathematical association study yet. And
certainly suggested by Zudin's talk, wasn't it, Steve, that it was, the recovery was to do with length of ICU.
Yeah, and is the damage seen in skeletal muscle mirrored in smooth and cardiac muscle or respiratory muscles? That's quite a tough question to finish on in the last 2 minutes that we've got. But those muscle groups are particularly hard to study, aren't they? I mean, the cardiac muscle we can look at by imaging surrogates, but we're certainly unlikely to get much in the way of biopsy.
I think I read somewhere that diaphragmatic muscle was also affected, but I'm not sure whether that was post-mortem or what.
Could be an indirect, couldn't it? Just looking at FEV1s and things like that.
Yeah,
I'm guessing. Yeah.
Yeah, there are studies ongoing that have been funded by BHF, so it'll be interesting to know, but certainly the fact that we have elevated myoglobin tells us that there is breakage going, blood levels, sorry, there's breakdown of muscle going on.
Well, we're certainly seeing, so one of my colleagues who's one of our cardiac imaging consultants, we've been following anybody with a positive troponin and they've been having cardiac MR. And certainly those patients that have been critically ill who have had elevated troponins, there is evidence of fairly durable myocardial damage. But then I think there are other patients who we were really anxious would have long-term cardiac damage who actually have recovered very well. So this picture's still mixed, but there's definite possibility. I think we're at 3:28 now, and I think we have to stop because to give people a chance to dive off and then rejoin for the next session. So anyway, I'm very grateful to you all for Gladys for your presentation and for Janet and Carolyn joining us for what I think has been a very interesting and varied panel discussion. Well, okay, well, thank you very much, and thank you very much for our audience for dialing in and watching the presentations and the discussion today. Thanks a lot. Bye-bye, everybody.
Everyone.
Bye.